good evening, everybody. My name is Mignon McCulloch. I'm the current chair of the South African Pediatric Association, and we are delighted that you are joining us for one of our webinars. So with that, I'm going to stop sharing and I'm going to ask Albeth Hoffman to do a presentation on the South African National Blood Transfusion Services.
I can see it now, Prof. Is it fine?
Perfect. Good. All good to go.
All right, thanks. So just a short background, I work as a general pediatrician in a regional hospital in Pangeni in the north of KZN. And just as a quick 5-minute advertisement, like Marty sold it to me, I'm just sharing a short presentation I did as part of my duties as a regional pediatrician in terms of doing a blood transfusion audit in this beautiful part of the country where I'm working, and then had to remind myself of where this very critical resource actually comes from. And just like to say thanks to Prof. Mike Harrison. His guidelines for more conservative blood transfusion has been very helpful. And it's just interesting that when you move away from academics, there seems to be an increased use of blood products when your options are a little bit less. So I'm sure many pediatricians will share this, that we're not often guided by protocols, but I've often reflected back on my training with Prof. Harrison and used it I think, successfully. So basically, I looked back just quickly and just saying, where does blood come from? And actually, I'm sure you all know, but I mean, we should remind ourselves that blood comes from the South African National Blood Service, which is in fact a non-governmental organization that receives absolutely no funding from government, but makes its income through selling blood to hospitals. So it's obviously a product that is wanted. There's a market for it, but it's still not manufactured in a factory, and it's still dependent on donors. And interesting, as it's very clear from the South African National Blood Service, that only less than 1% of South Africans are active donors, which is very little, and that blood doesn't last forever. It's not an indefinite resource and only lasts for 42 days, and that the South African National Blood Service actually has an aim of collecting about 3,000 units of blood per day to ensure safe and sufficient supply for healthcare services. So essentially, I just looked at a few things, and the first thing that really impacted on the South African National Blood Services service is a COVID-19 lockdown, and they've declared that they've seen their donor pool shrunk by nearly 120,000 donors, with a near 10% drop in collection during that lockdown period. And this was probably related to a work from home policy, people not going out and donating, and limited access to eligible donors. Very interesting that South African National Blood Service goes out to tertiary institutions. It's one of their biggest resources, and that didn't happen in 2020. So we had less blood, and come 2021, there was actually a significant increase in demand. And the South African Blood Service is actually running at quite a critical level. And I think besides the impact, or like Prof says, first to do no harm with our patients and transfusion, but also to have a clear idea that we actually have a very critical resource. And the next big shock came just a week and a half ago in the province where I work, where civil unrest really had a significant impact. And this is just a Twitter feed that all of you guys might have shockingly seen, where South African National Blood Service shut all its centers in KZN for a week, because there was significant looting of a few of their branches during the civil unrest period. And the direct impact anecdotally at our hospital was that in the obstetrical service, there was a patient with significant postpartum hemorrhage that could not be helped because there was no blood available. And we saw delays for urgent transfusions of up to 3 to 4 days, including all blood products was limited. And suddenly this resource, which became very critical, and we realized what a huge impact it is maybe to a lesser degree in pediatrics, but certainly in oncology and in our setting in the obstetrical community service, it had a great impact and probably led to mortality. So really just an eye-opener of this organization that's actually quite vulnerable in terms of this type of a disruption to services. So for the purpose of this short presentation, I went to the South African National Blood Services website, which is actually a great website. And basically, they almost weekly update their stocks. What do they have, and they report on how critically low they are and what they need. And it's quite clear. And so what we do now is I need to try and share weekly with my colleagues is like, what is our supply, and really to try and to make people realize that it's a critical supply. We need to look at our protocols. We need to, if it's not doing any harm, be more conservative with blood transfusions in the pediatric service. And the other thing we highlighted to our team was looking at the price, the cost of blood transfusions. It's easy just to write up, no, give him platelets, but there's no idea what that type of cost at regional level and certainly at our districts can do. So I'm not going to go through the details, but the South African Blood Service gives you updated costs of what the actual products cost and also what the accessories and administration sets also cost. And I think it is very relevant in our resource limited places to consider this and to think, is it really going to make a difference to our patients? The other issue certainly South African National Blood Services promotes is the counseling of patients and caregivers regarding transfusion reactions, and we highlighted this to our staff that we just, as in consultants, and all of them are just prescribing blood, but do we really counsel our patients on the significant transfusion reactions? And from a pediatric perspective, looked at which one was the most common. We know the febrile non-hemolytic transfusion reaction seems to be the most common, and we do at least 2 or 3 exchange transfusions a month. We use whole blood, and it's actually most commonly seen in whole blood transfusion. So are we counseling our patients? And so we use the opportunity to highlight it to our staff. And these were just images from actually from nursing sites, which gave quite a good approach to the basics and how to manage it, blood transfusion reactions. And essentially what I found quite nice was in a quality improvement meeting in my hospital, I found the nursing staff to have excellent SOPs in how to manage transfusion reactions. Some of them, us as consultants, were not aware of. So the exercise of looking back into it and going to look if those resources exist in our hospital was really helpful and insightful, and led to some quality improvement actions that we thought we need to improve and hopefully still will with new protocols. And it's great to have that type of backup, things we can refer to like Prof. Harrison's guidelines. So thank you very much for that. And in the end, I think I've donated blood 3 times since I'm back in KZN, which is the most I've done in 5 years, because I've suddenly realized how much we need it up here. And so to promote this to health staff, and very little doctors actually donate in our hospitals. It's much more the nurses. So I think you don't have to be a doctor to save life, just donate blood. And we've got a lot of young, healthy doctors, so we should be donating. Thank you very much.
Thank you very much, Albeth, for a really relevant topic. I think you're a great advocate, and really encourage everybody to get out there and donate blood. I had no idea that we'd gone down by 120,000 donors. That really is huge. And I think when you work in a hospital where there's lots of surgery, lots of trauma, I think you always just presume that blood is on standby. I'm a bit allergic to blood transfusions because I'm a kidney doctor and I don't want to sensitize my patients, but I really think this topic is really making us think a little bit out of the box. So thank you for that. And then our next speaker is Jan du Plessis, who comes from Bloemfontein, and he tells me it's really nice and warm there during the day at the moment, but freezing cold at night. And he's going to be updating us on transfusion triggers in children. So really interesting. We'll see how it matches with the neonates. And Jan, the floor is all yours. If you want to start sharing.
Hi, Minion. And hi, everybody. Yes, this is not just a talk about transfusion triggers. Mati actually asked me to talk about an approach to anemia in an older child. And Mike has already highlighted what the definition is, but the important message that we need to remember is that anemia is not a diagnosis by itself. It's actually a manifestation of many diseases, and one actually need to go and look and try and find this cause, what has actually caused it. This is just a table to remind ourselves what the normal levels are, and that anemia is actually then less than 2 standard deviations of what you would have expected it. So as Mike has said earlier, an approach to anemia is that you first do actually need to decide, is this an absolute anemia or is this a relative? And then when you decided it's anemia, then decide, is the patient actually losing the blood, destroying it, or actually not producing it? And as you can see, there's hereditary and acquired causes in both the decreased production and increased destruction phases, and we will highlight on this during the talk. So one need to be very systematic and judicious in your approach, and you should involve the whole history, examination, and special investigations in your workup of the patient. So if you do this systematically, you will eventually get to a cause. Very important to use the entire history to your advantage. And there's many elements in the history that is actually associated with specific causes. And we need to go back to what we taught to the students, that you need to be systematic in asking your questions. So go and look at what your patient's characteristics, look at the age of the patient. As well. Mike has highlighted what happens to the neonates, but with the infants, then basically for 3 to 6 months age, nutritional deficiencies is unlikely. You're going to probably find more an inherited cause like hemoglobinopathy, whereas with intolerance and adolescence, an acquired cause like iron deficiency is more likely. And screening is actually recommended for all children 9 to 12 months of age. And then just look at the risk factors: excessive cow's milk intake in toddlers, and look at the early onset of menarche in adolescent females, because we get to deal with a whole lot of them of the patient. The sex of the patient will also help you, because certain of the causes is X-linked, like G6PD deficiency and sideroblastic anemia. Then obviously with the girls, look at their excessive menstrual bleeding as well. And then to look at the race and ethnicity, this will guide you towards certain hemoglobinopathies and enzymopathies like hemoglobin S and C, thalassemia syndromes, and G6PD in all the mentioned ethnic groups mentioned in the talk. And then I like things to be nice and simple, that I can remember these things. So ask about symptoms. So we always ask about the symptoms. How does the patient feel? Obviously, is the patient symptomatic or not? But then you need to remember to ask about questions like, what's the color of the urine? Look at the patient's sclerae when they walk in, or does the patient have jaundice as well? That will point you towards hemolytic anemia. Obviously, we need to ask about stools, hematemesis, severe epistaxis, pica behavior, infectious symptoms, because all of these will lead you towards what you need to investigate. If the patient had prior episodes of anemia, then most likely an inherited cause. But if the patient actually had a documented normal full blood count previously, then an acquired disorder need to be thought of as well. And as you can see, for the neonatal, ask about the neonatal period. It is not just to know about, but there's a few things that you need to think of, like the hyperbilirubinemia, the jaundice. There could be a hemolytic disorder that was missed in that period. There's many underlying conditions. I work in the oncology field, so many of the oncological diseases presents with anemia, but also renal, inflammatory and autoimmune disorders may be associated with anemia. And then when we ask about drugs, you need to also ask about toxins. What happens to when they take in fava beans? Have they been exposed to paint, home renovations, the use of imported or glazed ceramics, with lead toxicity as well? And or is there any other families that had anemias, or that they present with jaundice, gallstones, or splenomegaly, because that will point you towards an hemolytic anemia. Then when you look at diet, obviously, we all know what to ask for iron deficiency. So go and make sure about that. The excessive cow's milk, because there's many of these parents that complain that their children don't eat, but they drink a whole lot of cow's milk. So these patients are at increased risk of iron deficiencies. Travel history, quite important, because that will, if they went to an endemic area, obviously think of malaria, and then obviously TB endemic areas. And then certain of the anemia causes is associated with developmental delay, even though we've seen quite a lot of patients with Fanconi's anemia at my unit, and I must say almost none of them has been had developmental delay, but it is something to remember to ask about. Then when you examine a patient, well, the skin is the largest organ, and then there's a whole lot of skin to look at. And one need to specifically look at, you don't just look for the pallor and the jaundice, also look for associated features like petechiae and purpura, because that's going to point you towards more something like a bone marrow infiltration, bone marrow aplasia, autoimmune hemolytic anemias, hemolytic uremic syndromes. But then a yellow color of the skin with iron deficiency, like we said, ulcers on the lower extremities with sickle cell diseases and anemias. And as mentioned here at the top, hypo and hyperpigmentation. So as you can see on this arm, there's a lesion with hyperpigmentation. Hyperpigmentation, this patient is pale. Typical small eyes, pocket-shaped mouth, triangular faces. And then when you look at the hands, the abnormal thumbs, thinner eminences. So this is a patient with typical Fanconi's anemia, which we seem to have quite a lot here at our unit as well. So because that will, as you can see, all of these will point. Look at the nails of the patient. As well, because spoon nails will point you obviously towards something like iron deficiency. The head of the patient and the face is quite prominent. So patients with frontal bossing, think of a congenital hemolytic anemias, thalassemias, prominence of the malar or maxillary bone, severe iron deficiency. So there's just examples of these as well. And as I said, there's multiple things with the eyes. The small eyes is the most frequent thing that we think of. But then just to remember to look at the blood vessels, because they will help you to identify a patient with possible sickle cell disease, patients with cataracts, like G6PD, galactosemia, with an hemolytic anemia in the neonatal period as well, retinal bleeds with chronic or severe anemia patients, edema, that will help with the renal failure, or even infectious mononucleosis patients. And then we've got currently a rare case of a patient with osteopetrosis. And blindness is obviously one of those causes that one need to look at. Children like to cry when you examine them, so the mouths are quite easily accessible, and look at them as well, because a glossitis or angular stomatitis can point towards a nutritional deficiency like B12 and folate, iron deficiencies as well. The chest of the patient, if there's an absence of pectoral muscles, think of something like Poland syndrome. Again, these patients are at a higher risk and need to be screened for leukemias. And patients with a shield chest could be like a patient with Diamond-Blackfan anemia. And yes, we've all been faced with a patient, and we're currently being faced with a patient with an enlarged spleen that we need to investigate. Is this now a leukemia? Is this a lymphoma, acute infection? Is this portal hypertension? Is there any evidence of hemolysis? Because all of these is associated with anemia. Then we get to the laboratory investigations, and as Mike has said, you need a full blood count with the red blood cell indices, peripheral blood smear, and the reticulocyte count. However, they do say that if you've got a patient younger than 2 years old who present with a mild microcytic anemia, and they've got the typical suggestive history of an iron deficiency anemia, you don't need to improve the diagnosis, but I'll allude to this a little bit later in the talk. So how is anemia classified? So basically, they use the red blood cell size and the physiological response, namely the reticulocyte response, to classify the patients, because this helps you to further narrow the diagnostic possibilities. And this is a quite useful table and quite that I found in one of the talks as I was preparing. And as I teach my students, so with the reticulocyte count, think of decreased production when it's low, or increased destruction when the counts are low, and there's the causes. So as Mike has said, you get many algorithms, but this is quite a useful one, and I think one that we definitely, and I refer to quite a lot, because you need to look at the size of the red blood cells, look at the red blood cell distribution volume, big width actually, to see does the patient actually make quite a number of different sizes of the red blood cells as well, and what's the reticulocyte response, because these will all guide you. There's the low hyperchromic or microcytic anemias, the normocytic anemias, and the macrocytic anemias, and there's all the further testing that we're going to go through in a bit. So as I said, if you've been presented with a patient with a low hemoglobin, then basically ask you if there's a true anemia, yes or no. And if it is, what is the MCV? Is there, and actually just look at the other cell lines, because if the other cell lines is affected, we need to follow a whole different route, which I will highlight at the end of this talk. As well. So patients with a low MCV, there's many causes such as an iron deficiency, thalassemias, sideroblastic anemias, and there's obviously many different tests and things that one can do, therapeutic trial of iron, review the diet history, do a hemoglobin electrophoresis. This was actually quite a useful algorithm that I thought, if you find a patient with a low MCV, because we are faced with iron deficiency in so many of the children, that you basically need to ask yourself, is this a mild one? Are the history and the red blood cell indices actually consistent with an iron deficiency anemia? And if you think so, yes, then basically you don't need to test further. You can treat them presumptively. But this relies on you seeing this patient again in 1 month's time and check whether the hemoglobin has increased by 1 gram per deciliter, yes or no. If it did, then yes, you've confirmed the diagnosis. You counsel your parents about cow's milk consumption and about how they need to improve their diet. And obviously, you need to continue with your additional iron therapy for another additional 1 to 2 months to replenish the stores. If the patient didn't respond, or the patient was not consistent, history is not consistent with an iron deficiency, then one can perform your iron studies, hemoglobin electrophoresis, lead levels as well, because this is now when iron deficiency anemia, anemia of chronic disease, thalassemia are possible. And if you can't find a cause, then obviously refer to a pediatric hematologist for further investigation. And this is just quite useful when you look at the MCV and the red blood cell count divided by each other, the Mensa index, whether to decide whether this patient has got a thalassemia or an iron deficiency anemia, because that can be easily confused. And obviously one need to do a hemoglobin electrophoresis to diagnose a thalassemia patient as well. As I said, we want to look at the MCV, and if we've got now a normal or a normocytic anemia, then you need to ask yourself, what is the reticulocyte response of this patient? Is it low or normal, or is it actually high? And if it's high, is there evidence of hemolysis, yes or no? Because that will guide you towards either hemolytic anemias or actually bleeding. So when you're faced with a normal MCV, but the reticulocyte count is actually normal or low, which actually indicates then bone marrow hypofunction, then look at the patient and then decide whether this patient has got a medical disease or infection, or is there underlying inflammation, or does the patient actually have an abnormal smear? So you have to look at the smear to decide whether you need to consider a bone marrow disorder, or if the smear shows toxic granulation and abnormal lymphocytes, that points you towards infection. And as said in one of the previous slides, you need to do the lead testing levels, because basophilic stippling, if you do see that on your smear, then that will point towards that. If the patient has got seems to have underlying inflammation, then consider iron studies to make the diagnosis of anemia of chronic disease. And if you consider a medical disease, then basically to go and look for and test for renal, liver, or thyroid disease, or do your bacterial cultures or viral studies to look for viral infections. If the patient actually has a high reticulocyte response with a normal MCV, then you need to obviously ask yourself if there is evidence of hemolysis, yes or no. If there's no, then it is either bleeding. And the confirmatory testing for hemolysis includes then indirect bilirubin, LDH, and haptoglobin levels. And then you can further do your direct antiglobulin testing, basically Coombs, to help and assist you. As you can see, the causes include hemolytic anemias, ABO, autoimmune or SLE diseases, or it could include membrane disorders or enzyme disorders like spherocytosis, G6PD, and PK deficiencies as well. And as Mike has said, the smear definitely helps you. If you see spherocytes, that will point you towards a hereditary spherocytosis or to autoimmune hemolytic anemia. Fragmented cells will point you towards a microangiopathic anemia. Heinz bodies, that will tell you that this is a G6PD deficiency, and obviously elliptocytes and sickle cells for elliptocytosis and sickle cell disease. Patients with a high MCV, the main question that you have here is basically you need to look at the peripheral smear, because you want to look to see if there is hypersegmented neutrophils or not, because that will indicate a megaloblastic anemia. So if you do see the hypersegmented neutrophils on the peripheral blood smear, then a possible megaloblastic anemia test for the B12 and folate levels. If it's obviously low, then you can treat them clinically and if appropriate, or refer them. But if both is low, consider other bone marrow disorders, and you can refer these patients. If it doesn't have hypersegmented neutrophils, do the reticulocyte count, because if it's low, then you need to go and look for bone marrow disorders such as hypothyroidism and liver disease. Leukemias will come into that role as well. And if it's high, then consider a hemolytic disorder. Just going back to the previous slide where it's highlighting the multitude of causes, as we said, liver disease, thyroid disease, patients with bone marrow disorders such as myelodysplasia, there were inherited bone marrow failure syndromes such as Fanconi's anemia, black diamond blackfan anemias, nutritional deficiencies, drugs and toxins, one must not forget that they will cause also high MCVs and actually a bioeuropean pancytopenia in these patients. And as mentioned earlier, how your smear will definitely help you and what your further testing would be. So now we're back to the very first slide where we actually have other cell lines that's affected. So when you are faced with a patient with a pancytopenia, obviously in my world, very important to exclude a patient with leukemia, but then also to look at drugs and toxins. As I said, patients with hypersplenism, there's a multitude of systemic viral infections, but also bacterial infections that will cause a pancytopenia, and it's quite important to remember that B12 and folate is important in RNA synthesis, so that will definitely cause a pancytopenia. And then to, as I said in the examination, to clinically look for signs of an inherited bone marrow failure syndrome, such as Fanconi's anemia, Diamond-Blackfan anemia comes to play a role there that one can see. And then there's others that one need to diagnose with a bone marrow investigation, such as an amegakaryocytic thrombocytopenia. And we are following a patient up that was referred to us with by the dermatologist with disc keratosis congenita, that these patients can actually also later develop a bone marrow failure. So if you are faced with a patient with anemia, so a bicytopenia and a low platelet count, then your hemolytic uremic syndromes, TTP, DIC patients, and Evans syndrome plays a role. Anemias with high platelet counts, obviously iron deficiency. Post-splenectomy, we see this quite frequently, or patients with severe infections. So I'm currently looking after a young lady in ICU with actually a leukemia, but faced with a massive intrabacter septicemia, and her platelet count is actually quite high at times as well. And anemia associated with low platelet count or a normal platelet count infections and leukemias one need to consider. So the smear will definitely help you to look for blasts, fragmented cells, toxic granulation, hyperpigmented neutrophils that will help you with the B12 and folate as well. And then very important to review the medications, review the diet history, do the serum B12 folate levels, test the iron, go and look for hemolysis, do your direct antiglobulin testing, viral studies that we do. And in the patients that we frequently see, we will also do the screening because we see Fanconi's anemia. So we'll do a DEB to check for patients with Fanconi's anemia. But this was actually also something that I found very simple, useful. And it is actually just tells you to use your common sense, think in global terms. So basically ask yourself, is the red cells being lost? So with blood loss, GIT bleeds or menstrual bleeds, or is the red cells actually not being made? So with a nutritional deficiency, or is there a transient shutdown by the bone marrow in a healthy patient with TIC? Or is there something like a bone marrow infiltration that will make this bone marrow not make red blood cells, or aplastic anemia and its multitude of causes? Or is the actual red blood cells being made appropriately and then being destroyed with autoimmune hemolytic anemias? Or is the red blood cells actually being made correctly, not being made correctly, and then destroyed with hereditary serocytosis? Or are they made with the wrong hemoglobin or with an enzyme defect, and therefore the patient is hemolyzing? So with patients with sickle cell or thalassemia or G6PD. So that is quite a simple way of thinking about anemia in an older child. And this is just a practical approach that I looked at. We need to remember, I want to leave you with the anemia side of the talk, to remember that anemia is a manifestation of many diseases. You need to have a rational approach, which is based on the history examination and a stepwise laboratory investigations. There's certain crucial investigations that one need to do: full blood count, MCV, the reticulocyte count. The one that I left out here is that you ask your friendly hematologist to look at the smear and tell you what they see, but then to remember to also include a bilirubin, direct antiglobulin testing, and then possibly hemoglobin electrophoresis. So, but the basics is, if you do a good drill through the clinical laboratory investigations, that will enable you to identify the cause of the anemia and reach a diagnosis. So simple: investigate your patient thoroughly, look for the clues, ask for the clues of the patients. Then you will have a logical and simple approach of how to approach these patients. So the next half of the talk is transfusion indications, which is actually for an oncologist something that, yes, I listened to the previous talk about all the restrictive therapies and things as well. And yeah, we are definitely far more liberal in the oncology world as well. But why do we actually to transfuse these patients? So the aim is that a transfusion can be life-saving. So in cases with severe blood loss or severe chronic anemias, and it has been alluded to that transfusions actually has a multitude of risks. Volume overload, there's a multitude transmission of infectious agents, transfusion reactions, immunological reactions, including graft-versus-host disease, which was highlighted. So when you consider to transfuse a patient, you need to weigh the expected benefits against the potential hazards. And obviously the benefits needs to outweigh the hazards in these patients as well. So as said, the transfusions, you want to give it to prevent or reduce morbidity and mortality, which is associated with anemia, but you also want to avoid unnecessary transfusions. Your aim is to provide sufficient cells to prevent or reverse tissue hypoxia. However, there's limited data on what hemoglobin level is actually necessary for tissue oxygenation. And in the literature that I reviewed, they said there's actually a multitude of animal studies that was done and where they looked at what is the hemoglobin that is necessary for tissue oxygenation. Obviously, they found that a hemoglobin less than 5 has got an increased risk of mortality and other adverse outcomes as well. So the value that they mentioned was a hemoglobin of 6.7. So as said, it's really difficult to assign an absolute level of for at which you would transfuse a patient. But if you've got a stable, critically ill patient or child with the focus on stable, they use a threshold of more or less 7. But one need to remember that the minimum tolerated hemoglobin in a child is not necessarily the optimum hemoglobin. And as I said previously, and I just want to highlight this again, to transfusion practice, you need to balance the threshold versus the risks of the transfusion. So this led me to reading about a restrictive strategy where we actually want to give less blood. We will transfuse the patients at a lower hemoglobin level and we are aiming for a lower target hemoglobin. So this is what I'm far more used for my hematology patients as well. So again, this is recommended to use a restrictive strategy in patients who is hemodynamically stable, and that for any hospitalized patient or a patient with a critical illness, and use a threshold then of 7. Whereas in my little world, where I live on the 10th floor here at Universitas, we use obviously a more liberal strategy where we give more blood and transfusing at higher levels. But obviously the causes of my lower hemoglobins is different because it's most of the time either the disease or my treatment that is causing these patients to have low hemoglobins, and that's why we would. But other conditions where you would transfuse at higher levels would obviously be patients with acute blood loss from trauma or surgery, patients with cyanotic congenital heart disease, and patients with chronic anemias like sickle cell and thalassemia. So this led to this table with the transfusion indications, where obviously if you've got a patient with a hemoglobin less than 7, a transfusion is then obviously often indicated. However, if the patient is asymptomatic and I need to highlight the next point quite well as well. If you've got a specific therapy available, like iron for iron therapy, you will treat these patients if they have got a lower hemoglobin like of 6 or even 5 at times as well. Then one need to remember about this one about symptoms is that there is a lot of these patients with chronic anemias that will not have symptoms when their hemoglobin is less than 6 or 7. However, you will find then other patients that will have symptoms at much higher levels. So the transfusion and decision about transfusing based on the symptoms need to be done at the discretion of the physician who's looking after this patient and depend on the clinical setting of the patient, as highlighted with patients with hemoglobins between 7 and 9 grams per deciliter, where you will look at the presence of bleeding, presence of active hemolysis, or if the patient is symptomatic or not, depending on the cause, obviously, as well, and how severely sick your patient is. And as said, hemoglobin is often unnecessary in hemoglobins more than 9, but it may be appropriate, and it will depend on the clinical situation of these patients as well. Factors to consider when you transfuse, and not to just use the values in a book or in a guideline, is to look at the acuteness of the anemia, the critical illness or the cardiopulmonary status of the patient, whether this patient is undergoing surgery or not, and underlying medical conditions. So I'm just going to look a little bit about this as well. As said, patients with chronic anemias will tolerate hemoglobins as low as 6 to 7 grams per deciliters, and they are able to maintain an adequate intravascular volume and tissue oxygenation at this level. However, patients with acute blood loss and hypovolemia will need transfusion at higher levels, and it will obviously depend on the extent of the blood loss. So like me, that dropped my hemoglobin after my surgery by 5 points, obviously, fortunately didn't need it because I was able to tolerate the blood loss quite well. Critical illness and the cardiopulmonary status, so we always have to look at that. So obviously, if the patient is unstable and anemic, you will transfuse them. If the patient has a compromised cardiopulmonary status, and that could be highlighted by unstable shock or severe hypoxemia, definitely they will need a transfusion, but not to transfuse if the hemoglobin is equal or more than 7 grams per deciliter in most critically ill patients. So they need to be hemodynamically stable and not severely hypoxic. And again, congenital heart disease, cyanotic congenital heart diseases, acute brain injuries, patients with sickle cell anemia, malignancies, recent bone marrow transplantation, or trauma-related acute blood loss are exceptions to this rule. Surgery. In the preoperative management of a patient with anemia, obviously you need to go and look for the cause and then initiate the treatment for this patient, but this is obviously not feasible in the emergency or urgent situation or urgent procedures. Perioperatively, this will be individualized to the child and the clinical setting, whereas a patient would present with rapid bleeding, symptomatic anemia, or evidence of hypoxia. And the evidence of hypoxia is highlighted by lactic acidosis or ischemic changes on the ECG. You will transfuse regardless of the hemoglobin level if the patient has any evidence of tissue hypoxia. However, if a patient is asymptomatic, you will follow a restrictive pre-procedure strategy rather, and to then have a threshold probably for surgery depending on what the expected blood loss would be with for a hemoglobin of 8. And intraoperatively, this will obviously be at the discretion of the anesthesiologist and the surgeon, where they will transfuse the patient if the blood loss is more than 15% of the patient's body weight. Underlying conditions, as highlighted previously, higher target levels is warranted in patients with conditions associated with chronic anemia, such as sickle cell disease or leukemias, as I do quite frequently in my little world. And I'm going to end off with this table, which I found in a very nice guideline. And I am only looking at infants older than 4 months of age. The thresholds is obviously for a stable infant to use a hemoglobin of 7 as threshold. Infant that is critically unwell, hemoglobins of 7 to 8. Patient with perioperative bleeding, hemoglobin of 8. Patient with cyanotic congenital heart disease, hemoglobins of 9. Thalassemia, also 9. Sickle cell disease, you will vary between 7 to 9. And then will also with sickle cell disease, depends on if the patient had a previous cerebrovascular accident or not, or are they due for surgery where you will use a higher level as well. Then regarding platelets, obviously we always say it depends on if the patient is bleeding and what's the cause of the patient. So if the patient has got a reversible cause for the low platelet count, with the emphasis on reversible, this would be a stable infant older than 4 months old. They must be stable. Then you will use a level of 10. I actually worked in a unit where in the oncology world, if the patient is stable and not sick, you will only transfuse if the platelet count is less than 5. To restrict the use of platelet and not to expose the patient to the unnecessary transfusions as well. Whereas one need to remember infants or children with that's in the ICU, a level of 20 can be used as well. And any infant with a platelet count or that is lower than 50 or 100 that you will transfuse them for a child that needs an invasive procedure or surgery as well. And then I've just added a little bit about FFP and cryoprecipitate, where you will give either if the APTT or the PT is more than 1.5 times the control for the age, or the fibrinogen levels is less than 1 gram per deciliter. So that's it from my side. And now we will move over to the questions. Thank you very much. Hello.
Hi there. Thank you very much. That was really excellent. I'm just going to go into the chat. We've got a little bit of time. I'm going to go from the bottom up. So how often do you find lead poisoning? Just wondering how useful a test it is to do.
Obviously, I'm in the oncology world and we work at the tertiary center. I haven't found it that frequently, but we've been caught out once or twice. So we rather test for that.
Okay, fair enough. Then I know you've covered a bit of this. We also see a fair number of Fanconi's anemia. How do you normally manage them short of stem cell transplant? I don't know if that's possible in this forum.
Yeah, that's quite a big topic for another day, and we don't do stem cell transplants here with us. And you actually, and I think the question would be there whether you give them transfusions or not, because you're exposing them to a whole lot of antigens and things, so that will make the transfusion, transplant quite difficult. So we actually put our patients on androgens prior, but then you need to monitor the liver functions quite frequently, and the androgens is with the fact that that will stimulate the bone marrow to produce more red blood cells, and trying to keep them transfusion independent. So that's basically what we do here in Bloem.
That's brilliant. Thank you very much. And I think that's really important, the point you've made. For any child with chronic organ disease who may need a transplant, the more you transfuse them, the more you expose them to other foreign antigens. So when a organ does come up, it makes them untransplantable. So my view is, if someone's not in oxygen and their hemoglobin is low, they need to go down to 4 before I would consider transfusing them as a renal patient. So I think the take-home message from everybody is think before you transfuse.
I think so too. That's very important.
Then I've got a question for Mike. Fully breastfed term babies, is there a need to add prophylactic iron while waiting to be on high iron containing diet or food?
Thanks, Mignon. It's the beauty of being online is that I've got younger and cleverer colleagues WhatsApping me, and I've got Google. So the AAP guidelines do say that term healthy infants who exclusively breastfeed.
Is that? Let me just try and silence that person.
Because the phones are much smaller.
Sorry, Mike, I've now muted you by mistake. I'm just trying to find you again.
Okay, I've unmuted. It's fine.
Great, fantastic. Thank you.
So I said, yeah, the AAP guidelines say infants who exclusively breastfed should receive milligram per kilo oral iron day beginning at age 4 months, so a bit outside of my term, and should continue until appropriate complementary foods that contain iron are included in the child's diet.
Okay, and then thank you for the lucid presentation. That's to you, Mike. I'm curious that your unit's transfusion guidelines or cutoffs are not postnatal age specific. I suppose the cutoff values for transfusion of prem infants should reduce with increasing postnatal age.
Okay, a good question. They are in a part, particularly whether they ventilate. We use a 28-day more or less. But guidelines need to be simple and easy to follow. And if you try to put something for every single gestation at every single hemoglobin, you would have a guideline that was impossible to use. And the gain you get from that is minimal. So we try and keep wide, big groups and keep it to a minimum.
Great. And I think there was just one more question about the tract guidelines with neonates in mind.
Again, thanks to my colleagues. So, it's a study that was done. It's in children, not in neonates, but it was looking at 20 versus 30 mils of blood transfusion. But I understand that the primary outcomes showed no difference between the two. So the recommendation is that practice isn't changed. But again, I had that sent to me. I didn't know that.
Great. So I think I'm going to call it a day because we've done an hour and a half. So brilliant. Thank you so much for the enormous audience that we had for this. Fantastic speakers, all three of you. Really thought-provoking. Just to remind everybody about the Congress, which is the next event in the SAPA calendar. It really looks good. I've seen some really nice presentations and some really nice topics. So please feel free to come and join us for that. And then 2 weeks after that, we're going back to COVID-19. I must say there's been good and bad with COVID, but the one thing about COVID is it's really enabled us to have good discussions with people across the country. So that's really great. And I just want to say thank you very much to Mike. Thank you to Jan. Thank you to Albert. And thank you to Mati for putting this all together. I wish you a safe and peaceful evening, and we'll see you at the Congress. And if not, we'll see you at the COVID webinar at the end of August. Thank you very much, everybody. Sorry, I see somebody's asking me to send the details for the payment of membership. It is actually on the website. Thank you very much. And we hopefully will be able to access the presentation later. Thank you so much and have a good evening. So with that, I'm going to stop sharing and I'm going to ask Albert Hoffman to do a presentation on the South African National Blood Transfusion Services.
Okay, good afternoon, everybody. Yeah, I'm Albert. Thanks for the opportunity. Is the slides coming up? Just checking if you can see the backdrop.
You just need to go to your slideshow.
And yeah. Right, so I can see it now, Prof. Is it fine?
Perfect. Good. All good to go.
All right, thanks. So just a short background. I work as a general pediatrician in a regional hospital in Mpangeni in the north of KZN. And just as a quick 5-minute advertisement like Marty sold it to me. I'm just sharing a short presentation I did as part of my duties as a regional pediatrician in terms of doing a blood transfusion audit in this beautiful part of the country where I'm working, and then had to remind myself of where this very critical resource actually comes from. And just like to say thanks to Prof. Mike Harrison. His guidelines for more conservative blood transfusion has been very helpful. And it's just interesting that when you move away from academics, there seems to be an increased use of blood products when your options are a little bit less. So I'm sure many pediatricians will share this, that we're not often guided by protocols, but I've often reflected back on my training with Prof. Harrison and used it to, I think, to successfully. So basically, I looked back just quickly and just saying, where does blood come from? And actually, I'm sure you all know, but I mean, we should remind ourselves that blood comes from the South African National Blood Service, which is in fact a non-governmental organization that receives absolutely no funding from government, but makes its income through selling blood to hospitals. So it's obviously a product that is wanted. There's a market for it, but it's still not manufactured in a factory, and it's still dependent on donors. And interesting, as it's very clear from the South African National Blood Service, that only less than 1% of South Africans are active donors, which is very little, and that blood doesn't last forever. It's not an indefinite resource and only lasts for 42 days, and that the South African National Blood Service actually has an aim of collecting about 3,000 units of blood per day to ensure safe and sufficient supply for healthcare services. So essentially, I just looked at a few things, and the first thing that really impacted on the South African National Blood Services service is a COVID-19 lockdown, and they've declared that they've seen their donor pool shrunk by nearly 120,000 donors, with a near 10% drop in collection during that lockdown period. And this was probably related to a work from home policy, people not going out and donating, and limited access to eligible donors. Very interesting that South African National Blood Service goes out to tertiary institutions. It's one of their biggest resources, and that didn't happen in 2020. So we had less blood, and come 2021, there was actually a significant increase in demand. And the South African Blood Service is actually running at quite a critical level. And I think besides the impact, or like Prof says, first to do no harm with our patients and transfusion, but also to have a clear idea that we actually have a very critical resource. And the next big shock came just a week and a half ago in the province where I work, where civil unrest really had a significant impact. And this is just a Twitter feed that all of you guys might have shockingly seen, where South African National Blood Service shut all its centers in KZN for a week, because there was significant looting of a few of their branches during the civil unrest period. And the direct impact anecdotally at our hospital was that in the obstetrical service, there was a patient with significant postpartum hemorrhage that could not be helped because there was no blood available. And we saw delays for urgent transfusions of up to 3 to 4 days, including all blood products was limited. And suddenly this resource, which has become very critical, and we realize what a huge impact it is maybe to a lesser degree in pediatrics, but certainly in oncology and in our setting in the obstetrical community service, it had a great impact and probably led to mortality. So really just an eye-opener of this organization that's actually quite vulnerable in terms of this type of a disruption to services. So for the purpose of this short presentation, I went to the South African National Blood Services website, which is actually a great website. And basically, they almost weekly update their stocks. What do they have, and they report on how critically low they are and what they need. And it's quite clear. And so what we do now is I need to try and share weekly with my colleagues is like, what is our supply, and really to try and to make people realize that it's a critical supply. We need to look at our protocols. We need to, if it's not doing any harm, be more conservative with blood transfusions in the pediatric service. And the other thing we highlighted to our team was looking at the price, the cost of blood transfusions. It's easy just to write up, no, give him platelets, but there's no idea what that type of cost at regional level and certainly at our districts can do. So I'm not going to go through the details, but the South African Blood Service gives you updated costs of what the actual products cost and also what the accessories and administration sets also cost. And I think it is very relevant in our resource limited places to consider this and to think, is it really going to make a difference to our patients? The other issue certainly South African National Blood Services promotes is the counseling of patients and caregivers regarding transfusion reactions, and we highlighted this to our staff that we just, as in consultants, and all of them are just prescribing blood, but do we really counsel our patients on the significant transfusion reactions? And from a pediatric perspective, looked at which one was the most common. We know the febrile non-hemolytic transfusion reaction seems to be the most common, and we do at least 2 or 3 exchange transfusions a month. We use whole blood, and it's actually most commonly seen in whole blood transfusion. So are we counseling our patients? And so we use the opportunity to highlight it to our staff. And these were just images from actually from nursing sites, which gave quite a good approach to the basics and how to manage it, blood transfusion reactions. And essentially what I found quite nice was in a quality improvement meeting in my hospital, I found the nursing staff to have excellent SOPs in how to manage transfusion reactions. Some of them, us as consultants, were not aware of. So the exercise of looking back into it and going to look if those resources exist in our hospital was really helpful and insightful, and led to some quality improvement actions that we thought we need to improve and hopefully still will with new protocols. And it's great to have that type of backup, things we can refer to like Prof. Harrison's guidelines. So thank you very much for that. And in the end, I think I've donated blood 3 times since I'm back in KZN, which is the most I've done in 5 years, because I've suddenly realized how much we need it up here. And so to promote this to health staff, and very little doctors actually donate in our hospitals. It's much more the nurses. So I think you don't have to be a doctor to save life, just donate blood. And we've got a lot of young, healthy doctors, so we should be donating. Thank you very much.
Thank you very much, Albeth, for a really relevant topic. I think you're a great advocate, and really encourage everybody to get out there and donate blood. I had no idea that we'd gone down by 120,000 donors. That really is huge. And I think when you work in a hospital where there's lots of surgery, lots of trauma, I think you always just presume that blood is on standby. I'm a bit allergic to blood transfusions because I'm a kidney doctor and I don't want to sensitize my patients, but I really think this topic is really making us think a little bit out of the box. So thank you for that. And then